Wow, what an amazing introduction. I know Everhart and Howie both were saying that they want to be acknowledged as young as well, and I will officially say that they're both young. But before I start, I have to take a moment. That morning session, in 2 years, I have not been as moved as that morning session. That was just fabulous. Now, don't be joking around there, Everhart, but that was just absolutely fabulous. Like what we heard there, the passion, the discussion about how things were and why decisions were made, and serendipity, and then seizing the moment. Oh my goodness, what a fabulous start to the day. And Howie, yes, I liked your talk as well, and George. They were all good talks this morning, so there we go. Do I just click here?
Yes, I think there is a clicker.
Oh, there we go.
See the clicker?
Disclosures. Okay, let's have some fun for 9 minutes. Unresolved questions in structural heart disease. Now, it depends on expanding indications. It depends on when you do this modeling. We've been doing it in Vancouver now extensively for about 9 months. But you could be looking at transcatheter and transcatheter between 30 and 50,000 cases per year by 20 to 32. And it really depends on a whole myriad of factors. So don't hold me to that number, but it could be a lot more than that as well. And I would say that lifetime management of severe AS and when if to treat concomitant CAD and when if to perform repeat Tavr are both crucial questions. We're obviously having a lot of interest in mitral, tricuspid, and other pieces, but I would say that these two factors, and we heard them touched on by Everhart and then John, are going to be crucial. So, Howie already did a beautiful job describing the rationale for the SMART trial. I need to do your logo, Howie, because that is a very straightforward logo. But I'm going to touch on complete Tavr, and then I'm going to chat about discordance Tavr, because I think it speaks to both questions. The concomitant coronary disease, obviously, with complete Tavr, and then the hemodynamic piece and doing repeat THV, and looking out and seeing people like Raj in the room here. You know, we've got the right people in the room to discuss this. Oh, went the other way. There we go. So, 3 quick slides just saying, you know you're in a good space when the number of publications looking at concomitant coronary disease or hemodynamics has just exploded in the last 12 months. Oh my goodness. Coronary revascularization in patients undergoing aortic valve replacement for severe AS. The nuts and bolts of this is we need prospective data. We know that surgical aortic valve replacement with concomitant CABG is Class C evidence. We know that we've got small trials like Activation and registries showing that if you have concomitant coronary disease, you do worse. And the more coronary disease you have, you do worse. But the question of revascularization affecting those outcomes is still up in the air. My colleague from Canada, Josep, obviously looking at this recent study. Here we could talk about it. It was 14 trials to get the Tavr plus PCI patients versus one center in North America for the surgical piece, but an interesting study. But again, if you look at the end of the conclusions, future trials are warranted. And then the explosion of interest in invasive hemodynamics. This became huge for John and I about 18 months ago. Obviously, the pendulum had swung. We were not doing routine invasive hemodynamics. We were not doing on-table echoes for all of our cases. But I would say now, because of this issue of repeat THV and when it is appropriate to do that, whether we're talking small, large annuli, whichever platform, has now landed square in the spotlight. And both of those last 2 references are this week. So we're in the right place. Complete Tavr. What a wonderful steering committee. So you can see the people on that list, including Roxana and others, to really try and decide what is the best way to structure this study. And I'd like to thank, obviously, the extended steering committee, as well as the executive committee, which is underlined my co-PI, John Webb, and John Cairns, our steering committee chair. And there's Raj in the audience as well. You can't see all this, but currently 106 sites. We might end up landing around 120 to 130 sites eventually to enroll all 4,000 patients. Currently North America, but I am twisting different people's arms to see if we can expand to select sites in Europe and Australia. So busy slide, and I'm going to show it twice. The first time, let's focus on coronary disease. So we heard from Everhart, obviously it's up to the individual patient, and if you believe that coronary disease is prognostically significant, absolutely, it always comes down to the heart team. But in a prospective 4,000 patient study in patients with severe symptomatic aortic stenosis, very simply looking at lesions that are 70% visual, the exact same thing we did with Shamir Mehta in Complete with the STEMI population, different population, much younger, but 70% stenosis in a 2.5 millimeter vessel. To John Webb's point, this isn't little distal OM, PDA, posterolateral vessels. We do the successful transfemoral TAVR. You have to have the TAVR first from a clinical trial point of view. You can't follow people for 5 years if they had PCI and then they ended up getting the THV. So the way this is structured is all 4,000 had successful transfemoral TAVR. You then have 96 hours to randomize them to either medical therapy or complete revascularization. Up to 45 days to come back. Most patients so far enrolled in the study, we've got 30-something centers up and running, are coming back at 30 days for a variety of reasons in the US. So either medical therapy or complete revascularization. We just heard from George the wonderful discussion about anticoagulation, and we've simplified this, and this follows on work from Raj and others. If it's medical therapy, so we're just going to treat medically that concomitant coronary disease, aspirin. If they have an indication for an oral anticoagulant, we would continue with that guideline-directed oral anticoagulant. We now have 3. On the other side, if it's complete revascularization, we've now given flexibility to the heart team, and this was a recent amendment with Roxana and Shamir Mehta and others, Rob Welsh, 1 to 6 months only for DAP if they get PCI. So very, very short because of what we just saw with the bleeding risk from the trials that George just presented. And then aspirin monotherapy. So as short as possible, aspirin monotherapy. If there's some comorbidity, the heart team decides for why you might want to do longer DAP, so be it. And if they're on an oral anticoagulant, it would just be the oral anticoagulant plus clopidogrel. And again, we've given you flexibility for 1 to 6 months. We think this represents the most current version of anticoagulation post-study. And then obviously primary heart outcomes, secondary outcomes, including the hemodynamics, which I'll come back to in a moment. There we go. So I had the privilege of being with Everhart at London Valves. Luckily, we got in and out, and we're all healthy. But on November 21st, on behalf of my co-PI, Amr Abbas, as well as Philippe Pibereau, John Webb, others, we were able to present the preliminary study on discordance TAVR. And this has already been highlighted by John. We all know when you have severe aortic stenosis, beautiful concordance between invasive and echocardiographic. This is actually highlighted in that nice JACC intervention review that came out yesterday. But once you put a bioprosthesis in, whether it's surgical or transcatheter, many of the assumptions in the Bernoulli equation fall down. Why is this important? My colleague Amr Abbas, as well as others, have beautifully shown the discrepancy that Howie highlighted between immediately and immediately post-THV, looking at small and large annuli, looking at all different platforms. We know this exists. I guess what we are trying to now puzzle out, both in discordance TAVR, and I'll come back to complete TAVR, so not just answering the coronary question, in select cases, does a hybrid approach utilizing both echo and direct invasive more accurately predict the need for intervention? And this comes, we heard from Professor Cribier, clinically, when you're going around the world, we don't want to see patients getting a second transcatheter heart valve if they don't need it. And I must say, occasionally we are seeing that, and we want to make sure that the patient's always first and it's appropriate. So this is the algorithm I'm working on with John and Philippe Pibereau and others, Roxana. Elevated gradient of 20 on repeat echo. And again, this is a high quality echo focused on a bioprosthetic valve. This isn't suboptimal images, where either the gradient's over the 20 or they meet VARC3 criteria for hemodynamic valve deterioration. They have a CT that shows no issue with either valve thrombosis, halt, any issue structurally with the valve, and then they come back for invasive hemodynamics. And here we have a very protocolized approach, takes 3 minutes, add it onto your normal TAVI case, and you have a simultaneous on-table echo so that the fluid status is the same. If there's concordance, they're both elevated, then you decide whether you're going to do a balloon dilatation or a repeat THV. Very logical. If there's discordance, we would argue that perhaps that patient doesn't require anything at this point, and the symptoms are multifactorial, like they are in many of our transcatheter patients, and we would just follow them. We did the 13-patient pilot study. The mean gradient on average was 6. And again, remember, this is not immediate now. This is long-term post-THV, anywhere from 3 months up to 6 years post-THV. The individual patients, echo versus invasive, and what happened. I thought this was very interesting. And to Becky Hahn's point, you cannot just substitute in invasive gradients into VARC. We understand that. But if you look at this, all 13 had a gradient over 20, and these are transcatheter patients, long-term follow-up post-THV. 5 met for VARC3. When you go to invasive, if you do use the invasive gradients, all 5 no longer meet. And when you look at outcomes, it was only these concordant ones, 4 of the 13, that still had elevated gradients, echo and invasive, that then went on for further reintervention. Obviously, small numbers, and we're doing a larger study. This was the publication. We're doing a larger study, and again, I'm always trying to twist Edward's arm. We're going to try and see if we can increase the number of centers and the number of patients. Initially, this is slated to be 50, but we're going to see how large we can make this. And I guess what I would say here is also we had the, right time, right place, Malcolm Gladwell. I know I have a minute left, but we had the opportunity to change the protocol for complete TAVR just in the nick of time for our first enrollments. So if you look, this is a crucial line. Standardized invasive hemodynamics with an on-table echo in all 4,000 patients. This will be a gold mine of information going forward. And we are saying that this is now standard of care. When they come back at any time during the 3.5-year median follow-up, if they have an echo gradient greater than 20, or they meet for VARC criteria, those patients, we're asking the 106 sites, eventually 120 sites, to bring them back for simultaneous echo and invasive hemodynamics, right and left. The exact same thing we're doing in discordance TAVR. I think this will be fabulous. This, coupled with the data from SMART, I think is going to inform practice. I'm also excited to announce that we have a sub-study that we just had our investigator meeting, at least for the Canadian sites. There's 18 Canadian sites, but we're going to be looking to sites in the US. I'm looking out at Raj, where when they come back for their stage PCI at 30 days, we're doing actually not just invasive hemodynamics, we're doing right and left heart full assessment and during the stage PCI at 30 days. And I think that information then tied to hard clinical outcomes will be a fascinating, significant sub-study. So we'll have the coronary results, we'll have the hemodynamic results, and I think it will hopefully answer some of these questions. Lifetime management, when if to treat concomitant CAD, but now when and if to perform repeat TAVR. Thank you so much.